Hi, everyone. My name's Andy Biggs. I'm Congressman from Arizona's 5th Congressional District. I'm grateful that you joined me today. I have a special guest today. I've got Dr. James Tadaro, who received his medical degree from Columbia University, Vagelos College of Physicians and Surgeons in New York, followed by completion of residency in ophthalmology. He continues to lead investigative research in COVID-19 at a global scale with multiple publications, including the first widely disseminated paper on chloroquine and treatment of COVID-19 in An Effective Treatment for Coronavirus COVID-19, and most recently, the first detailed expose on Surgisphere in a study out of thin air that resulted in retraction of the Lancet study on hydroxychloroquine. Now, we're going to get into that, but before we get there, um, Doctor, I've read some of your tweets, and I'm gonna read just a couple of them, and then let you respond and if you would.
All right, I'll try to defend them.
Again, thanks for being here.
No,
Dr.
thanks for
Fauci
having
is
me.
misleading the American people when he says that randomized controlled trials have shown hydroxychloroquine to be ineffective. Here's why. There's only one double-blind RCT on HCQ in early treatment of COVID-19. All of the other RCTs, Solidarity, Recovery, etc., were in very sick patients and are borderline worthless because they just support what we've been saying since March. HCQ is for early disease, not late. That's a key point to get into. And then the randomized controlled trial for early treatment of COVID-19 that Dr. Fauci is too embarrassed to even mention by name is the one done by the University of Minnesota, hydroxychloroquine in non-hospitalized adults with early COVID-19. Now, I'm not going to keep reading the tweets because you devastate that study, but I want you to address the study. But before you get there, let's get back to this very important distinction that you make that's not being made out there by the Dr. Fauci's and Birx and the people who are actually setting policy, the Dr. Redfield and those guys at FDA, et cetera, about HCQ being effective potentially for early onset of COVID versus those who have advanced cases, maybe already hospitalized, maybe already on ventilators, et cetera. Tell me why that's important and how you find that.
Sure, yeah. So, there's really multiple stages of disease with COVID-19, and the treatment of those diseases, of those different stages of the disease, varies dramatically. And something that really anyone that was deeply involved in investigative research on COVID-19 and hydroxychloroquine, or were on the front lines treating patients with hydroxychloroquine, has been arguing for really since March, me as well, is for early treatment of disease, okay? And that we're talking about within about 3, 4, 5 days of symptoms, all right? This is when the virus is replicating within your body, and it's the time when hydroxychloroquine can stop that viral replication. Once you enter late stage disease, you have this inflammatory response that starts to kind of become a vicious cycle that gets out of hand, causes a severe pneumonia, thrombotic events. And at that point, I think we were kind of saying since March that hydroxychloroquine is probably minimally or potentially not effective at all in those late stages. So what does, the NIH, the World Health Organization, these large institutional research groups do? They go study hydroxychloroquine in randomized controlled trials in patients who are on their deathbed. All right, we're talking about patients who have a mortality rate in those studies of somewhere between 20% and 50%. These are very sick patients that have had symptoms for over 2 weeks, that are either already intubated or pretty close to intubated, okay? And so I can see some of the logic behind doing those studies. You want to save those patients before, unfortunately, they succumb to the disease. But these were not the patients that hydroxychloroquine really should have been tested in. It really stands its best shot at being effective, and which is validated from a number of observational and retrospective studies, is early treatment of the disease. And so to kind of refer back and circle back to my comments, my tweet about Dr. Fauci is, the treatment of this disease is kind of all clumped together into hydroxychloroquine works or it doesn't work. And so when someone says all the randomized controlled trials of hydroxychloroquine show that it's ineffective, that's really misleading, okay? Because most of those randomized controlled trials were very late in the disease. They're not expected to work late in the disease. I focused on the Minnesota study because this is really one of, it's actually the only double-blind, placebo-controlled, randomized controlled trial in testing hydroxychloroquine in early stage COVID-19. that sounds very impressive, very formal, and a great study, placebo-controlled, double-blind, randomized trial. And it showed that there was no difference in symptoms. And so that's the kind of people will look at that and say, okay, so it doesn't work early either. And I think that from what I heard at the hearings, that was the message that Dr. Fauci gave the American people, is we have studies in early, mid, late stage disease, and the randomized controlled trials show that it's not effective. And so that's why I put out that tweet thread showing that really the main study looking at early disease is total, no offense to the authors and the researchers, but garbage. And, that tweet thread that's talking about medicine, which is usually very boring, and it was, I think, an 11 tweet thread, got about 4 million views, which is, really, I think, showing that the American people care to really understand what's going on with hydroxychloroquine, with COVID-19, to have this amount of interest in medicine.
Well, doctor, we get bombarded by this. You can't watch TV. You can't go to the grocery store. Everything in your life is now touched by this virus. I mean, it just is. I mean, so let's get back to something you said when you were talking about the multiple stages of COVID and how HCQ may work in the early stages, certainly not in the latter stages. And you said you wanted to start treatment within 3 to 5 days of the exhibition of symptoms or detection of symptoms. There are so many people that are asymptomatic that simply don't know that they even have this disease. So how do you deal with that? I mean, you're just not going to need to deal with that, actually. And so how do you
kind of answer that yourself?
Yeah. I mean, and CDC itself has said that you might have as many as 10 times the number of people have actually contracted the virus as have tested positive. So what does that mean with this notion of herd immunity that people talk about?
Yeah, so that was something that I really took a deep dive into back in April when we started to have some serology studies coming out, because I knew this virus is fairly highly transmissible, and that it took us a little bit to ramp up testing, which we did, but we surely didn't catch all the cases. Okay, so we knew that the actual number of infections was far higher, and so to me, what was important about that information is that would subsequently tell us that the infection fatality rate is actually much lower. Right? So exactly as you said, many people are asymptomatic or had very mild symptoms, didn't even know they had COVID-19. And so I put out an article with Dr. Zelenko and a couple of other authors in April, where we kind of assessed those infection fatality rates and said that it's probably appropriate that we can start reopening the economy at that time. And we did shortly thereafter, and that was really when deaths had spiked. But we know now, I think the CDC even has kind of put this out as well, the infection fatality rate is about 0.2 to 0.3%. Okay, so very low. This isn't really a disease that we were looking at in February, March, where we didn't know we were looking at people falling dead in the street, or a 3%, 5% mortality rate. It's actually far lower. And actually, in those people that do succumb to the disease, they're very advanced stage. They have severe comorbidities oftentimes, so either at the bare minimum obesity, but cardiovascular problems, pulmonary problems. And whereas in children or even middle-aged adults, it's actually very, very rare to pass away from this. And everyone has the story, the anecdote of a friend of a friend of a friend, but that's not science, and that's not how you determine actual kind of risks of this disease.
Yeah, thanks for using the term risk, because that's what I keep talking about. Is we're talking risk here, and you have to evaluate risk, because every aspect of our life involves risk. And so in Arizona, the reported case fatality rate or infection fatality rate is something like 2.1. But when you actually start extrapolating, getting that down to and you putting these things in context, it's really closer to 0.2 for that infection rate. And not only that, 85% of those fatalities are people aged 56 and older in this state. And so you can really isolate and determine who's really the most vulnerable population. And we chose not to do that, largely because of Dr. Fauci and Dr. Birx. I lay a lot of this on them because they were the ones providing the information and evidence ostensibly to create policy that was going out throughout the country. let's get back to the Minnesota study for a sec. One last second on that.
Sure.
So what was? I mean, you said here he's too embarrassed to mention it by name, because it has some major problems. I didn't even realize this till I had actually read your tweets.
Most people didn't. I had very smart people that contacted me and said, well, I mean, looks like the case is closed on hydroxychloroquine. There's a placebo-controlled, double-blind, randomized controlled trial about it, and it said it doesn't work, so it's done.
Right, and so tell us about the flaws in that study, and quite frankly, why should anybody even be believing that study after you've exposed it?
I don't know too many people actually believe in that study anymore. It's been, I think it was pretty soundly debunked there, and hopefully by going on interviews like this, it can help to getting the remaining people to believe in it. But it's, despite being a randomized controlled trial, it was at the end of the day really much closer to an anonymous online survey. Okay, so most of the patients in that study, so to give you a little bit of background on the study, it was about 423 patients who were determined to have COVID-19 and received either hydroxychloroquine or a placebo, which I believe was folic acid, and then they measured kind of symptoms at 14 days. That was their endpoint. And what they showed was that there's no significant difference between patients who received hydroxychloroquine versus folic acid at the end of 14 days. What isn't clear until you actually dig into the study is that only actually 34% of the patients in that study actually tested positive for COVID-19, okay? The other 66% either A, tested negative for COVID-19, so they actually have patients in that study who tested negative for COVID-19, or were not tested at all, okay? So they based really this positive diagnosis of COVID-19 on symptoms alone, which isn't great to begin with. But it's even worse because they didn't even see any of these patients, right? It was all done online. So anyone could kind of fill out a questionnaire, say they want to participate in the study, and then just fill out a static form saying what their symptoms are. This is no different to saying, getting a diagnosis of COVID-19 from WebMD. Would you go to WebMD, fill out your symptoms, and be like, I have COVID-19 now? Like that's not going to be a quality diagnosis. And so, there's a really good chance that a large percentage of the patients in that study didn't even have COVID-19. And so what does this mean for the outcome of the study? If a lot of the patients didn't have COVID-19, then hydroxychloroquine is probably not going to work. If you have a headache due to some other causes, or postnasal drip, or allergies, or a cold, the hydroxychloroquine is probably not going to help you. So it would diminish the therapeutic effect of hydroxychloroquine. And that's kind of what we saw with the study. And the other thing that isn't really obvious is they actually changed the endpoints of the study halfway through the study. So they realized that the number of hospitalizations or deaths, which was their first endpoint, was going to be very low. So they changed it to this kind of symptoms at 14 days. They should have still really addressed the original endpoint, which showed that there was about a 40% decrease in hospitalizations or death. Okay, but again, because there was only a small number, it wasn't significant. But that was really more of a problem of A, probably not having 100% of actually positive COVID-19 patients in the study, and B, it was underpowered. They needed more patients. So the outcome of that study, the conclusion should have been there is a significant trend toward decreased hospitalizations and deaths in patients with early COVID-19 when treated with hydroxychloroquine over placebo. A larger, higher-powered randomized clinical trial should be done. So that should have been the actual conclusion of the study, but instead they went in the direction of saying it doesn't work because of these 14-day symptoms. So,
and that leads to something that you said about institutional levels attacking hydroxychloroquine. And so when I look at it, and I'm baffled, to be honest with you, when I see this, because it is now orthodoxy that hydroxychloroquine not only doesn't work for COVID at any stage, but it's also dangerous. I mean, that's now the orthodoxy in the public. And if you say anything like you do or like I do, we get castigated for saying, well, there seems to be some stuff out here that makes this work. But when you talk about institutional attacks, I've seen it. I know you've seen it. What changed a drug that had been used in literally tens, if not hundreds of millions of cases over 50, 60 years a drug that's been deemed to be safe by the FDA. What moved that from a drug that nobody heard of unless you were going to a malaria-stricken country to absolutely, you had a Fox News commentator saying, if you take that, you will die. How did we move to that?
It's really unbelievable, and it definitely seemed to continue to escalate. A lot of people point to when the president first mentioned hydroxychloroquine, right? That was when a lot of the controversy began. But to me, one thing that's interesting is actually even before the president mentioned the drug, before it was even on the public's radar. If we go back to late February, so the president did his press conference on it, first mentioning it on March 19th. So if we go to late February, though, the assistant director general of the World Health Organization, Bruce Aylward, made a public statement saying that there's only one drug that showed promise for COVID-19, and that was remdesivir. Okay, that's an interesting comment at that time, because he was really basing that off in vitro. So remdesivir is Gilead's drug. I think most people are familiar with that. But at that time, there was only really in vitro evidence showing that remdesivir would work. And it actually came from a study that was published in Cell Research. So this is owned by Nature, which is a very well-respected journal. But that study also showed actually two things. It showed both chloroquine and remdesivir were highly effective in vitro in treating SARS coronavirus type 2. Okay? Yet for some reason, the World Health Organization completely put chloroquine, hydroxychloroquine aside and ignored it. Okay? Refused to investigate it, refused to do research on it. It wasn't until I co-authored a Google document with Mr. Regano, and we released it. And this was proposing chloroquine as a potential treatment for COVID-19. And Elon Musk tweeted out, it went viral, it got millions and millions of views, and I think that caught the attention of the world and the President of the United States. It was only then that the World Health Organization and those institutions were like, okay, well, I guess we have to look at hydroxychloroquine. And then they did look at it, and as I said before, they looked at it in the wrong way, the wrong stages of disease. But even beyond that, it's pretty obvious that there's been this kind of dismissive approach to hydroxychloroquine, and even so far as to, like you said, make it sound dangerous. So this is a drug that was approved by the FDA in 1955. I did a literature search some time ago on how many deaths there have been from hydroxychloroquine. And it's so rare that it's hard to actually get a number. But I saw a case report from 2007 that said that they could find from literature search about 20 deaths from hydroxychloroquine.
How many, 20?
About 20. And that was spanning...
Since 1955.
They did a literature search. That's probably mostly what's available online. But it's still going, a span of maybe 10 years or so, because that came out in 2007. Let's compare that to Tylenol. Okay, Tylenol is an over-the-counter drug, and there's about 25,000 hospitalizations every year from Tylenol overdoses. About 500 to 1,000 people die every year from Tylenol, from liver failure due to Tylenol. So when you're looking at hydroxychloroquine in that light, it really appears far less dangerous than Tylenol. Yet somehow, through these world institutions, through fraudulent studies that were published in the Lancet, kind of provided the mainstream media with the content, which wasn't real, but the content to drive this message to the American people and to doctors that hydroxychloroquine is the world's most dangerous medicine.
Yeah, so I want to come back to the Lancet piece that you were instrumental in having withdrawn. But before we get to that, I want to talk about safety. So I was the author of the right to try legislation that passed. I was disappointed because it wasn't more broadly written, but we had to deal with what you can get passed and signed into law. I view what we're seeing here as an absolute undermining of that patient-physician relationship. So what you've acknowledged is that since 1955, this drug, hydroxychloroquine and chloroquine, they're safe. I mean, the FDA has said they are safe to use, right? The only question that anybody really has is, are they effective along the stages of COVID? And so I guess my question is, if it's safe to use, why do we see the FDA, the World Health Organization, the CDC, pundits, Fox newscasters, all these people want to intervene between the patient and the physician, who might be saying, well, let's give this a whirl. This might work. We think this might work. They're denying the right to try is what I'm getting at.
Absolutely. And, you know, you've done a lot of research on this, and so you may know more about the kind of legal side. But to my knowledge, I've never heard of a medication that was essentially banned from prescribing off-label for another condition. I mean,
That's right.
This is, as you said, an FDA-approved drug. Usually what that means is that doctors can now prescribe it to patients. They're allowed to, okay? And they can do that off-label. That means that, you know, and that's how doctors work. That's what's the difference between a good doctor and a bad doctor. If every doctor just followed the exact robotic pattern and didn't use any of their own insight or experience treating patients, you know,
Right.
then you could be seen by a machine. You wouldn't have to see a doctor. But there's certain doctors that really dig into the literature and say and weigh the benefits and the harms of a certain medication. Say, well, there's some evidence that this works for a particular disease, and you talk it over with the patient. And the patient will be like, no, I don't want to try anything new, and that's fine. Or, you know, the patient might be like, well, what do you think, doctor? He's like, well, I've had great experience with this. You know, there's observational evidence that it works, and, you know, I think we could try it with you. It's a very safe medication. And then you do that. That happens all the time. That happened all the time in my clinics, okay? For some reason, with hydroxychloroquine, it's not allowed. If you write a prescription for hydroxychloroquine for COVID-19 or anything besides really lupus, rheumatoid arthritis, or maybe malaria, the pharmacies will block it. In certain states, you could get, penalized. Your license could be suspended. And so this is what a lot of doctors were, afraid of and had a difficult time getting these prescriptions to their patients. It's really unprecedented. Absolutely unprecedented.
Yeah, you're right. We've looked into it, and I find no evidence anywhere else that anything like this has happened. It's unprecedented, and it's quite frankly, it's dangerous, and it's had just a humongous negative impact on our society. And I mean, and I'm not just talking about the physical health, but I think this interposition of government bureaucrats between the doctor and the patient on something that, I mean, that the bureaucrats already said this is okay to use, is actually going to have long-term ramifications, which won't be good for patients or physicians.
Yeah,
So,
absolutely. I think physicians and patients alike should be outraged, but particularly physicians, because one of the, and I've heard this from multiple physicians, is how everything is now controlled by hospital administrators, from corporations, from bureaucrats, and it's really affecting the way they're able to actually control the treatment of their own patients. And this is a huge step into that control. And that's why I went together for the White Coat Summit in DC last week. That was one of the main things that we were there to talk about, to bring the attention of people and doctors. Like, wait a minute, this is a huge intrusion on the patient-doctor relationship, and something that is not good for this profession, not good for patients in the long run. Absolutely.
right, and okay, so I know we're running out of time, but I got to get back to the Lancet study. This was a study I think safe to say that a lot of people were relying on, and in their attack on hydroxychloroquine, and you noticed some stuff that as I've gone through and looked at that whole scenario, I'm grateful to you, because you started in political circles, we'd say you started looking at the crosstabs. You started looking at the actual roots of their study, and it was built on what appears to be a total fraud, because Surgisphere, as far as I can tell, is out of business. I mean, they're
gone. They're gone. Vanished.
They vanished into thin air. And it makes you wonder who these folks were. Tell us a little bit about this study, what you noticed, and how you brought this to public light.
Yeah, so I can't take 100% of the credit for debunking this study, because I have a lot of independent researchers that are kind of contacting me and giving me this information about this study. And so there are a couple of pieces that really caught my attention about the data inconsistencies with it, which is what kind of inspired me to look even deeper into the study. But to get a little bit of background on the study, so this was a study published in The Lancet back on May 22nd, and
A
involved about
very prestigious journal, right?
very prestigious journal. So The Lancet, to give you a little bit of context, Lancet is about the #2 most prestigious medical journal in the world. It's 200 years old. When a doctor sees a publication in The Lancet, that's almost like in the Bible. That's like God's word in medicine, essentially. It's usually highly trusted. And they published a study looking at 96,000 patients that ultimately show that hydroxychloroquine about doubles your risk of dying and causes heart problems. Almost immediate, so really bad for hydroxychloroquine, and kind of confirmed the media narrative that had been going on for the prior couple months that hydroxychloroquine is dangerous. Okay, the World Health Organization almost instantly suspended all of its clinical trials on hydroxychloroquine worldwide. So this is many countries, many studies that have been ongoing that had no data at that time to show this, that their patients were not being safely treated with the drug. Stop those. Dr. Fauci went in an interview with CNN's with Jim Sciutto and said, in all likelihood, hydroxychloroquine causes cardiovascular problems. And he didn't directly reference the Lancet study, but that was a study that just came out that showed hydroxychloroquine caused cardiovascular problems. So it seemed like at this institutional level, there was this immediate embrace of the results of this study. No critical research. These are huge institutions. This is their job, is to evaluate therapeutics for COVID-19. Okay, but they didn't. They totally embraced it, and if it wasn't for independent researchers like myself who were digging into the data and realized those inconsistencies, that would have probably been the study that shut down hydroxychloroquine and ended it. And maybe that's what they wanted. I don't know. But then, so we found out that the thing that really got me to look at Surgisphere is because the authors were starting to respond to some of these data inconsistencies, and their argument was, well, it's from this organization, the data, and their data is good. And they really reaffirmed it. Like, the data is good. The rest are just like, these little inconsistencies, no problem. And so I was like, well, let me take a look at where they're getting this data from. And I was appalled. Okay, the company that was doing it had really no digital footprint, no team, no personnel to put together a study that included 671 hospitals, artificial intelligence, machine learning. It was just unbelievable what they were saying they were able to do. And then, there's stuff like there's an erotic model for hire who's posing as the director of sales and videos, and just, it was very superficial appearing. And so after I came out with that piece, The Guardian came out with theirs a couple of days later, and the study was retracted within 2 weeks of being published. And this is, I think, a record for a study of this magnitude. I don't know if a study of this magnitude in such a prestigious journal had ever been retracted that long or that quickly. But it damaged the reputation of hydroxychloroquine, because so many people out there, heard it's dangerous. And so even though the mainstream media came out with a little report saying, oh, actually that study was retracted, most people don't hear that. Most people don't see that. And all they heard was hydroxychloroquine is dangerous. I thought that was shown. And they don't remember exactly why it's dangerous, but they remember that they were told that.
Yeah, what you did was shine light on what is really a total fraud. I mean, that whole thing was a total fraud. And I think because people had, for whatever reason, and you and I might talk offline what we think the reasons are, but for whatever reason, they want to dismantle this idea that hydroxychloroquine might provide either a prophylaxis or some kind of therapeutic value at any point. They don't want that for whatever reason. And so this study that was a fraud comes out. Of course they're going to glom onto it. I mean, they're going to hang on that thing and use it and exploit it every way they can. So I'm grateful to you and those other independent researchers that brought this truth to light. There's two other quick studies. I mean, we're out of time, but I got to get to these real quick.
Okay.
The one study right now that seems to be a problem is you had some docs giving essentially fatal doses of hydroxychloroquine to patients, and nobody should be surprised that when you give somebody a fatal dose of any medication, somebody's going to die. Do you know about that study? And
yeah, of course. So the one that first came out that was giving those high doses was the recovery trial by Oxford University. It's, when that trial came out, it was very interesting to me because we had all this. So usually the way studies work is you have observational evidence, retrospective evidence of something, and then the next step is to do the randomized controlled trial for repurposing drugs, at least. And so they came up with this randomized controlled trial, but instead of using the doses that the observational or retrospective data suggested, they used ones about 4 times as high of doses, which is just strange overall. Why, I guess. And so within the first day, I think they used about 2.4 grams of hydroxychloroquine, which if you look at Dr. Zelenko's protocol, Dr. Raoul, and numerous other people who were actually treating these patients outside of that clinical trial, they used about 400 milligrams to 600 milligrams on the first day. So it was incredibly high doses. I'm not sure why they did that, and they're defending it as not being lethal or not contributing to the mortality rate in their patients. And there's some good articles out there that kind of dive into that to show that maybe it did contribute to the death of patients, which would be really tragic. But it's really unclear why they use such high doses.
Yeah, that's bizarre to me. Thanks for expanding on that. The last one is a lot of people now are starting to use the Georgia camp where you get. Are you familiar with this? They have a summer camp and several hundred kids get there, and I think it's like 450 to 500 kids and counselors, and half of them end up with coronavirus, and so they're using that as a reason why you shouldn't open up schools anywhere. Of course, they don't bother to mention that no one went to the hospital and there were no fatalities with that. You had some headaches, you had some runny noses, and I think some soreness. So you're not familiar with that. That's just kind of happened, I guess, in the last few days, actually.
I have not heard of that Georgia camp. I did see that there was a study just published a couple days ago about the transmission, or at least the nasopharyngeal load of the virus in children versus adolescents versus adults. But my one comment on that, which is kind of your last point about none of them dying or even maybe being hospitalized, is that the mortality in children is very low, and a lot of people don't realize this. They think it's kind of dangerous across all ages. As of last week, there's about 86 children in the entire country who died from coronavirus. So 86, which, every single one of those deaths is absolutely tragic. And every childhood death from any car accident, suicide, domestic violence is absolutely tragic. But if we had to compare it to another disease, we could compare it to the flu, influenza virus, which kills about 500 children every year. 500 children every year, sometimes up to 1,000 per the CDC. So the influenza virus definitely seems to be far more lethal and have far more negative symptoms on children than coronavirus.
Well, gosh, I could probably talk to you another hour on this stuff at least because I'm fascinated by it. Dr. James Tadaro, thank you so much for your work and all you're doing.